I'd had headaches before, stress headaches, dehydration headaches, the kind you push through. This was not that kind. This is ER files, real cases, real decisions, what happens, why it happens, and what you need to know. Saturday morning, 10:42 a.m. Amara is 30 years old, sitting at her kitchen table. Coffee, laptop, sunlight, a birthday card propped against her mug. Everything is ordinary. She tips her head back, rubs her neck. A slight shift. Something feels different. Not painful, not yet, just off. Then it happens. In 1 second, both hands fly to her temples. Her phone drops. Her face is not a wince. It is a seizure of pain. It felt like a bat hit her. No. Like the bat came from inside. The coffee mug tips over. Liquid spreads slowly across the table. Her phone lies face down. A frozen stillness fills the room. What Amara just experienced is called a thunderclap headache. A headache that reaches maximum intensity within 60 seconds. This is a medical emergency until proven otherwise. You do not wait to see if it passes. Here is what was happening inside her brain. For years, possibly, a small aneurysm, a balloon-like weakness in an artery wall, had been sitting silently in the subarachnoid space, the space between the brain and its outer membrane, normally filled with clear fluid. Then it ruptured. Blood began flooding that space. Blood the brain cannot tolerate. It spreads through the cerebrospinal fluid, pressing on brain tissue, triggering massive pressure. The red bloom is expanding with every heartbeat. Amara slides off her chair onto the floor, not unconscious, just unable to hold herself upright. She holds the table leg. Every instinct said, just breathe. It will pass. You are fine. But something else said, no, not this time. She reaches for her phone. Call emergency services immediately if a headache reaches peak intensity within seconds. If you describe it as the worst of your life, if it comes with neck stiffness, vomiting, confusion, or vision changes, do not drive yourself. Do not wait. She is on the floor, phone to her ear. Her voice is controlled, but her hand is shaking. She says, I have the worst headache of my life. It started 1 second ago. I cannot stand up. Those words, exactly those words, are what saves her. The dispatcher is calm. Her triage screen routes the call immediately. Sudden, severe headache, possible neurological emergency. She sends units. She tells Amara, stay on the line, do not eat or drink anything. 6 minutes later, paramedics enter through the front door, which Amara managed to unlock while crawling. 2 EMTs, equipment bags. They move fast, but they move steady. The first EMT kneels beside her, takes her wrist, checks her pupils, equal, reactive to light, checks her blood pressure, 178/104, elevated. He asks her to rate the pain. She says 10. He believes her. He places both hands gently on her neck. He is checking for neutral rigidity, neck stiffness. When blood leaks into the subarachnoid space, it irritates the meninges, the brain's outer lining. That irritation causes the neck to resist movement. She winces. He notes it. Amara is on the gurney. An IV is started in her arm. Saline, drip, slow and controlled. The paramedic radios the hospital. 30-year-old female, GCS 14, thunderclap onset, BP 178. Suspected SAH, ETA 9 minutes. Requesting neurology on arrival. GCS stands for the Glasgow Coma Scale. It measures consciousness on a scale of 3 to 15. 15 means fully alert. 13 to 14 means mild impairment. Below 9 is severe, often coma. Amara scored 14. She was mostly okay, mostly. The hospital team was ready when she arrived. Emergency Bay 3. Monitors beeping to life. A crash cart visible in the corner. Dr. Chen meets the gurney. She has already read the paramedic's radio report. She bends close, makes eye contact. She says, we are going to take very good care of you. Inside Dr. Chen's mind, thunderclap onset, worst headache. BP 178, 30-year-old female, no trauma. She runs the differential. Subarachnoid hemorrhage, top of the list. Rule out meningitis, hypertensive emergency, migraine, but never assume migraine. Order a CT head, non-contrast, stat. The neurological exam takes 4 minutes. Pen light in both eyes, pupils equal, reactive. She asks Amara to touch her chin to her chest. She cannot quite make it. Neck stiffness confirmed. Reflex hammer, normal. Grip strength sensation, both intact. Speech clear. Every finding is a data point. Here is what that exam was checking. Pupil response tests cranial nerve function and brainstem integrity. Neck stiffness. Signals meningeal irritation, blood or infection in the fluid space. Reflexes and grip strength map the motor pathways. Speech checks the language centers. Together, they build a picture. Amara is wheeled into the CT room. Wide, white, still. The machine is a large ring with a hollow center. She is told not to move, not to swallow if she can help it. The table slides forward. The machine is louder than she expected. The whole scan takes less than 10 minutes. In the control room, the technician watches cross-sectional brain images populate on the monitor in real time, slice by slice. He is looking for one thing: bright white where there should be dark. There it is, a bright white star pattern at the base of the brain. Blood in the basal cisterns. This is the classic appearance of subarachnoid hemorrhage on a non-contrast CT scan. Dr. Chen sees it immediately. Confirmed SAH. Now they need to find the source. Neurosurgery now. Dr. Chen pulls a chair to Amara's bedside, not standing over her. Eye level. Deliberate. She says, "Your CT scan shows there is bleeding around your brain. It is serious, but you came in fast and you are awake and talking, which is exactly where we want you." Here is a myth worth correcting. Many people believe that if they were having a brain bleed, they would be unconscious. That is not true. Many SAH patients arrive awake and speaking. Being conscious is a good sign, but it does not mean the situation is not an emergency. Awake does not mean safe. Back into the scanner. This time with contrast, a dye is injected through her IV. She is warned she will feel a warm flush spreading from her arm to her chest. It lasts about 30 seconds. On screen, the blood vessels of her brain light up like a glowing tree. Dr. Chen and the neurosurgeon lean toward the monitor. The CT angiography has mapped every major artery. They are looking for a bulge, a weak spot, the source of the bleed. And there it is. Visible and unmistakable. Dr. Osi arrives, neurosurgeon. He shakes Amara's hand before he looks at her scan. She notices this. He and Dr. Chen study the images together. His finger traces a vessel. He says 7 millimeter anterior communicating artery aneurysm. Good candidate for coiling. On the monitor, where two arteries meet, a small balloon-shaped bulge, 7 millimeters. The anterior communicating artery. The most common location for cerebral aneurysms. Dr. Osei knows the statistics. Without treatment today, the rebleeding risk in the first 24 hours is around 20%. That cannot happen. An aneurysm is not a clot. It is a structural failure. The arterial wall loses elasticity in one spot and bulges outward, like a worn patch on a tire. The dome is thin. Under pressure, it ruptures. It can sit silently for years before that moment. The blood supply to the brain runs through a ring of interconnected arteries at its base, the Circle of Willis. It distributes flow to every major brain region. The anterior communicating artery sits at the front of that ring. When it ruptures, the entire system feels it. Subarachnoid hemorrhage is graded using the Hunt-Hess scale, from grade 1, a mild headache with a normal exam, to grade 5, which is coma. Amara presented as grade 2, moderate headache, neck stiffness, but no neurological deficit. Grade 2 carries a good prognosis. It means the brain is still coping. Dr. Osi sits with Amara and her partner Kofi. He explains both options. Surgical clipping requires opening the skull and placing a metal clip at the base of the aneurysm. Permanent, but a longer recovery. Endovascular coiling requires no skull opening at all. For this aneurysm, coiling is the recommendation. Here is the difference. Clipping, open craniotomy, metal clip placed directly. Excellent long-term seal. Coiling, access through the groin artery, tiny platinum coils threaded to the brain through a catheter, fill the aneurysm sac from the inside, trigger clotting. No skull opened. Shorter ICU stay. Preferred for small-necked aneurysms like Amara's. Before the procedure, Amara is moved to the ICU. Quieter. Softer light. A monitor beeps steadily beside her. A nurse explains each medication being prepared. Pain management, IV fluids for blood pressure support, and one critical drug, nimodipine. Nimodipine is a calcium channel blocker. After a subarachnoid bleed, blood sitting in the subarachnoid space irritates the arteries. They can go into spasm, narrowing, cutting off flow, causing a secondary stroke days after the initial bleed. This is called delayed cerebral ischemia. Nimodipine reduces that risk by roughly 30%. The procedure room, a hybrid operating and imaging suite, dominated by a large C-arm fluoroscopy machine, real-time X-ray that will guide every movement, screens everywhere. The interventional neuroradiologist will navigate catheters with millimeter precision using only images. No skull will be opened. Step 1. A small incision in the groin. A thin introducer sheath is placed into the femoral artery. This is the entry point, a highway that leads directly to the brain through the body's own blood vessels. Step 2. A microcatheter travels up through the aorta, through the carotid artery in the neck, and into the cerebral circulation. Every movement is visible on the fluoroscopy screen in real time. The entire path traced in live X-ray. Step 3. The catheter tip is advanced with precision into the dome of the aneurysm itself. The interventionalist is working in millimeters, guided only by the contrast dye and the images on screen. Step 4. Soft platinum coils are pushed through the catheter. Each coil curls and fills the aneurysm sac, like packing material, into a hollow space. The coils trigger clotting. The sac begins to seal itself from the inside. Step 5. A final injection of contrast dye. The image confirms it. Blood is no longer entering the aneurysm. The sac is full. The source of the bleed is sealed. The team exhales. Step 6. Catheters removed. The groin access point is closed. The patient is still and stable on the table. The entire procedure took 90 minutes. No skull was opened, no brain tissue was touched. Recovery room, softer light. Amara's eyes open. Kofi is there immediately, holding her hand. She looks at him and the tears come. Not from pain, from relief, from being on the other side of it. A nurse asks her to squeeze both hands. She does. Equal grip on both sides. That symmetry matters. It means no new neurological deficit from the procedure. Both hemispheres communicating normally. Dr. Osi appears. He says, everything went exactly as planned. The aneurysm is coiled, no complications during the procedure. Those words, exactly those words, are what she will remember for the rest of her life. Recovery after coiling follows a careful timeline. The first 2 days in the ICU, neuro checks every hour, blood pressure management, vasospasm watch. Days 3 through 7 are the highest risk window for delayed spasm. From day 5 onward, if stable, a transfer to the general neurology ward. Discharge usually comes between 7 and 14 days after the initial bleed. Days 4 through 7. Amara is sitting up now, still fragile, still attached to monitors, but her eyes are clear and she is asking questions. The nurses check on her constantly. This is the window they are most afraid of. Every morning, transcranial Doppler, an ultrasound probe held against her temple, measuring blood flow velocity through the cerebral arteries. High velocity means spasm. The artery narrowing, flow restricted. Today, the numbers are within normal range. Looking good, Amara. She asks, what happens if vasospasm starts? The nurse answers, we have protocols. IV fluids to raise the blood pressure and push flow through. Sometimes balloon angioplasty, going back into the artery from the inside and opening it. You are being watched closely, exactly so we catch it early. Here is what the brain was recovering from day by day. Day 0, blood floods the subarachnoid space. Days 3 through 7, the blood breaks down, releasing toxic byproducts that irritate vessel walls, the vasospasm risk at its peak. Day 14, the cerebrospinal fluid begins reabsorbing the debris. Weeks 3 and 4, the vessels return to normal tone. The brain begins to heal. The complications to watch for after subarachnoid hemorrhage. Rebleeding in the first 48 hours, the reason intervention cannot wait. Vasospasm in days 4 through 14, the reason for nimodipine and daily Dopplers. Hydrocephalus, the reason for close neurological monitoring. Hyponatremia, low sodium from hormonal disruption. Seizures, possible at any point. Day 12, Amara is wheeled to the hospital exit. Kofi carries her bag. She is in her own clothes for the first time in almost 2 weeks. She looks thinner, but her eyes are clear. She glances back once at the entrance. Then she gets in the car. In the car, she rests her head against the window. They told her she would be tired. They were right. They told her she would feel emotional in waves. Grief, relief, fear, gratitude, sometimes all at once. They were right about that too. The first months. Neuropsychological testing, concentration, memory, word finding, all assessed. A follow-up with her neurosurgeon at 6 months, a new CT angiography, the coils perfectly in place, no sign of the aneurysm reopening, physiotherapy to rebuild stamina, slow, steady, real. She is back at the kitchen table, same mug, same laptop, same light through the same window, but she is looking at it differently now. Recovery is not just physical. Your brain learned that something happened to it. So did the rest of you. Long-term recovery after subarachnoid hemorrhage. Fatigue, the most common and most underestimated complaint, lasting up to 18 months. Cognitive changes in memory and concentration, common and often improving with time. Depression and anxiety in up to half of all survivors. Return to work usually between 3 and 6 months. Follow-up imaging for years because new aneurysms can form. Now consider what could have gone differently. 3 paths from the same moment. Path 1, she called 911. Fast CT, treated same day, recovered. Path 2, she waited 2 hours. The aneurysm rebleeds in that window. Rebleeding before treatment carries a 40 to 60% mortality rate. Path 3, she drove herself, loses consciousness mid-drive. No neurochecks en route. The hospital receives no warning. The one thing to take from this story, thunderclap headache, maximum pain in under 60 seconds, means call emergency services immediately, not after the next episode, not in the morning, now. No exceptions. No waiting to see if it passes. Months later, Amara is writing in her journal. Normal life returned. She writes, I have thought a lot about that Saturday, about the instinct I nearly ignored, the voice that said, no, not this time. The doctors gave me a lot back that day, but so did I, by making that one phone call. Here is the full case timeline. 10:42 a.m., thunderclap headache onset. 10:49, 911 called. 10:55, paramedics arrive, GCS assessed, IV started. 11:09, ER arrival. 11:28, CT confirms subarachnoid hemorrhage. 12:15 p.m., CTA identifies the aneurysm. 2:30 p.m., coiling procedure begins. 4 p.m., procedure complete. Day 12, discharged home. Key anatomy, the subarachnoid space, the fluid-filled layer where the blood collected. The circle of Willis, the ring of arteries at the base of the brain that feeds every major region. The anterior communicating artery, the most common site for cerebral aneurysm. The coiling procedure, platinum coils, no skull opening, 90 minutes. Key numbers. Roughly 30,000 subarachnoid hemorrhages occur in the United States every year. 85% are caused by a ruptured aneurysm, rebleeding before treatment, 40 to 60% mortality. Nimodipine reduces vasospasm risk by 30%. Hunt-Hess grade 1 or 2 with prompt treatment, excellent outcomes. Go to the emergency room immediately for a headache that reaches maximum intensity within 60 seconds. The worst headache of your life. Even if you have had bad headaches before, headache with neck stiffness, fever, or light sensitivity, headache with sudden vision changes or one-sided weakness, headache after a head injury. Any of these? Call now. This has been ER Files. Amara is a fictional representative case. The medicine is real. If you or someone near you experiences a thunderclap headache, do not wait. Call emergency services immediately.